We ready to go?
Yep, go ahead.
Okay, hello everyone, I'm Stephen de Graaff. I'm based at Epworth in Melbourne. I've got my cheer squad behind me here. I'm hoping to take you through a little bit of updates with the management of botulinum toxin and spasticity, as well as really what's more important, the overall management of spasticity. We tend to have a big influence on botulinum toxin, but I really think that that probably is only the adjunct. But I have had several requests to make sure we do have a little bit of a discussion of botulinum toxin at the end, so we will do that. If we get started, I need to disclose that I actually do consulting and teaching for both Ipsen and Allergan, so I have a finger in both pies, and I'm a paid consultant to both companies for various activities. Within this discussion, we've got contributions from Dr. Helen Redmond, who is a rehab physician in Sydney, Gavin Williams, who's a physiotherapist in Melbourne, and Melissa Knott, who's an occupational therapist based at Charles Sturt University. What we'll try and work through is the pathophysiology of spasticity, then the management of spasticity, and then the role of botulinum toxin. We've got around 2 hours. I'd like to probably open it up towards the end for more open discussion, but I will stop on a couple of occasions just to give people a chance to ask questions if they've got some. And if anyone's desperate to ask a question, I haven't got your vision at the moment, but if the controllers can notice that, I'm happy to be interrupted. Thank you. Okay, I like to use the term window of opportunity because it really does, the management of spasticity is one of those things that really, it's never too late, but if we can get it earlier, it's a better outcome. So we need to look at the definition, its relationship with the upper motor neuron syndrome, the consequences, our patterns, and how do we measure, which will run into management. We've relied on the definition of Lance, which came out in 1980. This really related to the velocity-dependent increase in tonic stretch reflexes with hyperexcitability of stretch reflex. Bit narrow, didn't answer all the questions we wanted to really face up to. Cindy Ivanhoe put forward the fact that it's an umbrella term and often confused with other features of the upper motor neuron syndrome, which confused it even more. But fortunately, we're starting to use the European spasm approach, which was designated in 2005, which is spasticity arises from the upper motor neuron related sensorimotor dyscontrol, and it presents as intermittent or sustained involuntary activation of muscles. It's important to understand that there are a number of pathways involved in the evolution of spasticity, and for an example there we have spinal tracts and cerebral tracts of 8 numbers, but there's many more tracts involved. But the critical tract in all of this is the dorsal-reticular spinal tract. It's an inhibitory tract, so if it gets affected, then you have an element of spasticity arising. Interesting, a lot of people think that it's related to the corticospinal tract, but if you actually sever the corticospinal tract, you actually get some mild decrease in control without any evolution of spasticity per se. So the upper motor neuron syndrome has both positive and negative features. The most disabling are, of course, the negative, which are the fatigue and weakness in particular. When we're managing spasticity, we're looking at positive components of the upper motor neuron syndrome. And so we're only looking at a small select group of individuals who are troubled by disability associated with their neurological disease. The elements that we treat in spasticity are involved with the proprioceptive components, which really includes increased tendon reflexes with radiation. And so we encompass clonus into that. Other areas that can be managed, though, are dysynergic patterns, flexure withdrawals, and extensive thrust and pushing reactions, which are movement disorders. And this is a field in itself that's developing as we sit and watch. We have multiple areas for causes of the upper motor neuron lesion. Multiple sclerosis and stroke are the commonest in our community. Head trauma and hypoxic brain injury, spinal cord injury are particularly relevant to the rehabilitation field. And then we have the neurodegenerative disorders, including cerebral palsy and like. Why is it important to target upper motor neuron lesions? The fact is there are 2 ways to target them, because we want to minimise the long-term problem, which is contracture. So immediate consequences, including weakness and paralysis, lead to shortening from immobilisation, But delayed consequences, which are the positive signs associated with the upper motor neuron syndrome, involve rearrangement of spinal reactivity, and this is where spasticity and dystonia fall into play. Remembering also the dynamic issues such as spasm and clonus can impact as well. Excuse my voice. So, the pathophysiology of the upper motor neuron syndrome is complex, and our knowledge of it is not quite clear. We know it's more than just the stretch reflex, because there are things happening at the spinal intersection as well. What we do know is the upper motor neuron lesion disturbs the balance of the supraspinal inhibitory and excitatory inputs, and so then we have disinhibition of the spinal reflexes. This leads to more excitable alpha motor and gamma neurons, and this develops into the upper motor neuron signs and symptoms. If it was so easy, because the evolution is quite complex, pathways recover in various patterns and time frames. So we have some recovery partially damaged or shock pathways, and then we have to reorganise the cortical representation to maintain control. Inactive connections may then have to take over facilitation or disinhibition of the whole process, and this leads to inefficiency of movement. So along with your increased tone, you find movement is quite poorly controlled and differentiated. Other issues involve that can complicate the picture are also the fact that sometimes spasticity is not a bad thing. Many of us have treated patients thinking that if we reverse their spasticity in one area, we'll make things easier for them. And in fact, they can actually utilise their spasticity for improvements in function. And a good example of this is some of the control that occurs around the hip and knee in terms of spasticity. So we have to be quite selective in what we're targeting. We also have to remember that higher centre issues can also impact upon the outcome of management of spasticity. Inattention and neglect, by definition, mean that the patient's unaware of what's happening. Language deficits in terms of understanding what's been explained and what needs to be communicated. And then, of course, cognitive issues with attention, concentration, memory make it difficult for retraining. We may see problems with motor planning, coordination, delayed initiation of postural constraints. So even situations where we think we've got a pure motor lesion, we may well find that other pathways are involved in the overall recovery as such. And this complicates the picture enormously. When you read the text, we talk about the physical consequences, which are the restriction of movement, causing excessive and inappropriate movement or causing pain. What we're really interested in is interfering with function, whether it's active or passive. When we're trying to retrain, of course, we know that it interferes with physical therapy, has the potential to cause tissue damage as well as soft tissue and joint changes. And this is the area we want to target earlier rather than later. Okay, we might stop for a second because that's a very brief overview of the pathophysiology, and I'm happy to open up for some questions for a couple of minutes. I might even try and be brave here and see if I can get some pictures. Oh, there are people there.
There are people.
Any questions? Everyone's shaking their head. It's all clear as mud. All right. I'll try and get back onto the picture again. Okay. So that was a brief overview. Now we're really looking at. Hello, Gary.
Oh, hi, Steve.
Hi, sorry to interrupt, Dr. de Graaff. I think you've changed the screen that you're sharing. So if you can just go back into presentation mode, that would be great.
Yeah, I'm going to now. I just wanted to see who was out there.
Okay, no worries.
Okay, I'll go back into full view now.
Great, thank you.
How's that? Is that better?
Perfect.
Excellent. All right, let's talk about managing spasticity, and that's really what we really want to discuss today. It is on. We need to look at the general principles of managing spasticity and what sort of modes of therapy that we have. It's critical that you understand that the physical therapy and the day-to-day handling of the patient is more important than the medical and surgical management. These need to be seen as augmenting the overall management of the person. I just put this, there's a couple of slides I just put up just for a little bit of historical knowledge. For those who remember the 1970s, and it won't be many of you out there, we basically worked on the faith principle where you've had the stroke or the neural damage and it'll either get better or it won't. We moved into the 1980s and we became a little bit military based and had inpatient management. And everything was rigid, and basically although we talked about the functions of the individual, we fitted in with the hospital needs. I'm pleased to say that we've actually moved into the 2000s and we look at it as a diversified rehabilitation program. And really what this means is that we can look at a number of ways in managing the person, whether it's in hospital, in daycare situations, outpatients, or in the community. And that's really what it's all about, because we want the person to be able to be rehabilitated into their environment as easily as possible. Interestingly though, however, the measurement issues that we use in terms of quality of life, spasticity, aren't that great because it's a specific area that's measured in a general process. However, I have to re-emphasise that reintegration into society is really what we want, and it's about participation. There are multiple factors that are relevant to neurorehabilitation. The patient themselves is critical. Now that's often a little more difficult with this group because there may be cognitive issues that are impacting upon things, but we need their commitment, we need their motivation, we need them to be able to participate. And if we have that process, then we can look at what we can do. In terms of how you target this, you have to set SMART goals, which can be achievable in an appropriate period of time. Satisfy your therapy to assist with this management, and the intensity and frequency of the therapy will vary from individual patient to individual patient. There may be more emphasis on physical, there may be more emphasis on cognitive, it depends on the person. And you like to have a mixed interaction process. The therapist is key in the management of this once the communication channels and the relationship is set up. We need to be able to communicate what we're trying to achieve with the patient, have the ability to participate in that decision-making process and set goals that they feel that are relevant to them. At times we will have to deal with goal setting that is not necessarily in the interests of the patient, but is within their pie in the sky dreams, and we have to look at doing things in a stepwise process to try and minimise the disappointment that they may not achieve what they were hoping to achieve. No stroke or head injury is the same, and everyone will have a different background and a different goal setting. The environment is also important. We like to think that we can work in an enriched environment which is positive and progressive for the patient. We can adapt to their needs, involve family and friends, and have a good team approach to the whole situation. You all heard of ICF and where the spasticity fits in the control of voluntary movement functions. So when we're trying to measure what we're doing here, we do need to consider the ICF approach. B760 is control of voluntary movement functions, and this can be broken down further into simple voluntary movements, complex voluntary movements, coordination, and supportive functions. You probably don't have to be as complex in that, but it gives you a good structure to work from in terms of what you're trying to achieve. So what are we trying to do? We want to improve function, we want to relieve pain, we want to prevent contractions of pressure areas, and we want to decrease the cost of care. Because you may be aware that our government at present is concerned about how much money we're spending on patients, so we need to rationalise what we're doing. There is no single treatment for spasticity. It's a combination of interventions, and it's determined by the individual themselves, their needs and their goals. What we do know from the studies is early spasticity management is more effective, and hence the discussion on the window of opportunity, and this allows us to enhance motor control. The unfortunate thing is that most of the studies in terms of managing spasticity are beyond the 3-month mark. So we're still trying to gather data in terms of what happens earlier than the 3-month mark. This is a very basic slide. It comes from Twitchell, who was an English neurologist in the mid-50s, and he was the first really to describe what would happen if you treated spasticity either early or late. And basically what he came to the conclusion is what we see now. Even though we may not make as great a gains when things are put on hold, there is still potential for improvement. When I first started treating in this area, I was seeing patients who'd been managed at home, being told there was nothing else to do. Fortunately, we moved on from that, and we now know if we can target things that we can improve quality of life and function in a lot of ways. So a person with any form of neurological deficit has potential for improvement if they're able to participate in the process. So what are our modes of treatment? Now, in the slides at the end, which you'll receive, I've got appendices with some of these findings. But physical modes of treatment, the first thing you need to do is avoid exacerbating factors and minimise nociceptive inputs. An example of this is really painful foot, bladder dysfunction, or like where you have neurological drive, which is distressing for the patient. This will increase their spasticity. I like talking about the situation where you come onto the ward at 8 o'clock in the morning and you can work out whether you've had a relaxed environment for the patient overnight or a stressful environment for the patient overnight. Invariably, if it's been a relaxed environment, patient's positioning and posture are usually pretty good and their spasticity is not too bad. If they've had a stressful night with a run-in with the nursing staff or another patient, you'll come in and they're really quite distressed and their spasticity goes off. And that's a good example of nociceptive negativity. Posture and seating is incredibly important. Stroke, for example, stroke and head injury management start from day one. It's not all just about the medical model or the surgical model. We need to start addressing issues that may arise, both preventative and treating. And positioning and seating is incredibly important, particularly for minimisation of contractures and abnormal postures. Physical therapy, which you know probably a lot more about than I do, we can have both passive and active management, and we're getting better evidence now for constrained therapy, so things are improving in that area. In the more severe cases of spasticity, splinting and casting is important. You see that tends to be used more in acquired brain injury than stroke situations, but it can be used in stroke situations as well. We'll have a little chat about medical therapies, which are principally pharmacological, and also a brief discussion on surgical therapies, which should be limited at best. When we look at the management of the patient, there are a number of critical factors for our decision-making process. How does the spasticity present? What is the positioning? Is it flexible? What's the positioning in the arm or the leg? And the trunk at times, we tend to underplay the trunk's role. In terms of the goal domains, what do we want to treat? Why do we want to treat that? And what do we hope to achieve? Perfection is rare, but if you can work through your patient to target goals that will improve their movement or their positioning or their pain or their comfort, these can be achieved. There are some patients that will select for botulinum toxin. There are others that we won't. It's rare for me to initiate with botulinum toxin injection without some input from my therapy team. It's incredibly important that the patient's assessed appropriately, not only from their impairment level, but from their function and quality of life level. Once we start treating the patients, we should have tools for assessment and outcome measures. And any patient who is treated with injection should have some form of follow-up in terms of management. And it's a team approach that makes the greatest difference. So there's a four-way team. It's actually four's only a category term. There's often more members in the team than four. Open communication is important. It's essential that you don't promise something that can't be achieved, because you set these patients up for failure if you try to promote something that's not achievable, and they're often struggling with self-esteem and life to start with. It's best managed with experienced therapists, but we also need to take the responsibility of training up others for future management. And mutual respect across the board is important. If you don't succeed, it's better to be open and say, we've done something that hasn't worked here, or the goal wasn't achievable, or like, you should never be defensive about what you're trying to do. If we remind ourselves of the clinical manifestations of spasticity, we may have reduced active function. Reduced passive function leads to hygiene issues, increased care burden, and issues with tissue breakdown and infection.
Take no responsibility. You can get a worse person than me.
What?
Oh, sorry.
When we're measuring impairment, we're looking at passive range of motion, resistance, passive range of motion, deformity, and a lot of situations have contracture. When I first started talking about spasticity management, one of the rules was that we never treated contracture with our spasticity tools. But in fact, we can manage, as long as it's not a fixed contracture, we can manage contracture much better if we can get down their spasticity. So it's important to be aware of that. If we've got involuntary movements, it may well be important to try and dampen these down, because these can affect safety and movement and can cause pain and like. We want to target mobility often in these patients. And mobility is an interesting situation because, in fact, although we tend to predominantly target lower limb management, as this is seen to improve independence much greater than upper limb, the studies are much stronger in upper limb at present than they are in lower limb, which I find fascinating. But we'll get there. And don't forget pain. Spasticity-related pain will certainly improve with the use of toxin and the use of appropriate therapy strategies. But neuropathic pain is also an issue that can be managed both with therapeutic input and therapy input, as well as toxin can have a role here as well in certain situations. The last area, of course, is psychological impact. Someone with spasticity usually has some challenges in facing up to the distortion of their body image, and so treating this can also assist with self-esteem and improvement in body image. We've borrowed these from Ibsen. These are, the next couple of slides are about positionings that you'll often see in hemiplegic situations. The upper limb flexor pattern with adducted internally rotated shoulder, flexion at the elbow, pronation and supination at the forearm, flexion at the wrist, flexion at the fingers, and abducted and flexed thumb. That's probably the commonest presentation, and there's 4 other presentations there, with the first on my left, which should be your left as well, being the next. No, sorry, the second should be the next most common, and the first on left being the next common. Interestingly, the fourth there, which looks like an Erb's palsy, when we first put out these slides, I'd never seen a spasticity picture like that. And I sort of made a few comments when we were putting out the slides, but within the next month I saw 2. So it does happen. But the most critical thing in all of this is static patterns are only helpful if your goals are related to passive function. And one of the things that's changed over time is we've become much more proactive in terms of managing active function. And this has changed the way we manage things, particularly given that we're working more in the community now. Was someone wanting to ask a question?
No, that sounded someone connecting in and someone connecting out as well, so don't worry.
Oh, okay, excellent. And don't forget you need to look at the patterns of the spasticity of the hand as well. Because a lot of, you may well find people have good proximal control, but distal control's down, or distal care's down, and it may just target distally. And just quickly remembering lower limb patterns with equina varus at the foot, hip flexion, thigh adduction, knee extension, toe flexion, and the hitchhiker toe or great toe extension, which I think is fascinating. Okay, how do we measure spasticity? Traditionally, we've targeted using the modified Ashworth scale and more recently Tarju scales. These measure impairment, as do pain scales really, which are visual analog scores. But now we're starting to look at ARMA, timed up and go, 10-metre walk test, 6-metre walk test in terms of active processes, and then goal setting with goal attainment scaling, which allows us to review what we're trying to achieve. And as clumsy as it seems at the start, it actually does improve the way you record what you're trying to achieve, but also allows you to reflect on where you've been and where you've moved towards. And I find the tool a very useful tool. You can target down the various tools with MAS, Tarju and GAS being involved with function, passive function goals, ARMA, ARAT, Wolf motor function test, GAS for active function. Impairment can involve MAS, Tarju's muscle strength, passive range of motion and GAS. Mobility with timed up and go, 10-metre walk test, 6-minute walk test and GAS as well. And pain using VAS and GAS. The Ashworth scale, we're still using it principally because the pharmaceutical board expect us to use the Ashworth scale when applying for botulinum toxin. And more simply, the Ashworth scale is 5 scale with 0 to 4, and in the modified Ashworth scale, which we've added 1+ for the slight increase with minimal resistance. The issue about the Ashworth scale is it doesn't actually measure spasticity. What it measures is resistance, and you need to keep that in mind. The Tarju scale was first introduced in 1954 and then disappeared. The reason it disappeared was that there were 3 papers presented in French, and the English, being the powerful nation that they were, didn't want to have anything to do with French papers. But fortunately, in the mid-70s to early 80s, physiotherapists started reflecting on the Tarju scale again, and it allowed us to really measure the impairment associated with spasticity, looking at velocity, quality of muscle reaction and angle of catch. One of the things that the research has shown is that the MAS can be confounded by contraction. That's because it's measuring resistance rather than spasticity. So this really does mean that the Tarju scale is more valid in terms of measuring the impairment that we're looking at. And we're measuring stretch, muscle reaction, and in terms of quality and angle. Just a quick synopsis. I'm sorry, there's no videos. If we look at this one, we have R2, 0 to no contracture, R1 to 60 degrees with your spastic reaction. This means your spastic angle is at 60 degrees, and spasticity is primarily contributing to impairment in that situation. Whereas if we compare it to this situation where we have R2 at 60 degrees, which is a minus 60 degrees elbow contracture, and R1 at 90 degrees with your spasticity reaction, that means your spasticity angle is 30 degrees and your primary impairment is your contracture because you've lost 60 degrees of extension. So what we target there is if we can get the spasticity reaction down a little further, we may well be able to treat the contracture with appropriate stretching and ranging. And possibly in that situation, if it is 60 degrees, considering splinting and casting for more penetration once you've treated the spasticity. Goal attainment scaling. It's a tool that we use to evaluate whether patients achieve the goals that we set out for them. And we use a standardised set of measurements. I'll show the scale in a second, but it's basically a -2 to +2 rating. The challenging concept here is that when you rate, -1 is your level where you don't get any change. Most people want to go to 0 for that. But 0 is rated within this as the goal achieved. And then +1 is better than what you expected, and +2 is much greater than what you expected. -1 means that you don't achieve the goal or there's no change. -2 means you get worse. Now, it's relatively confusing. I think one of the reasons it's relatively confusing is this was designed by psychiatrists and they're playing with your minds. But once you get used to the concept, it actually isn't too hard to utilise. But the biggest challenge is to understand the difference between -1 and 0. It's been validated. It's sensitive to measure change for any given individual, so it's purely about that individual. And we know that we can utilise it following physical therapy and botulinum toxin injections. It also allows us to record the goal achievement and complement our standardised measures. The chart looks like this. We often set up the patient with 3 goals. You can do as many goals as you like, but it becomes a little bit more cumbersome beyond that. We try and set the goals to the person's wishes. Sometimes we do have to adjust for that, but it's best if the patient can set the goals themselves, because that means it's patient-driven. In terms of measuring your validity, you can weight the goals to importance and to difficulty. The researchers like that, we tend to target looking at their scores and the changes from -1 and where from it goes from there. It looks harder than what it is, and then it becomes even more difficult if you want to use the scale or the equation. But that's for the researchers. But you can copy it down if you like. As a result, we did the upper limb study using gas the first time around, and what we found is that the doctors who were injecting with a botulinum toxin weren't listening to the therapists, but we were still getting positive results. But as a result of the successful first upper limb study, we moved into EULAS 2, and what this targeted was looking at what the goal areas that were the primary areas of concern for people. And in fact, when we looked at the studies, passive function was the greatest area targeted, and 85% achieved their primary goal. Active function was a little less in terms of achieving goal, but active function's a lot more complex to measure and to manage, and this is where one of our challenges in the future is to become smarter in that area. Impairment, which runs along a little with passive function, was better achieved in terms of primary goals. Involuntary movement is about the same. Interestingly, mobility wasn't quite as good as people hope, but there's an influence there, and that is people want to walk normally, whatever that means. And so the reflection often isn't as great as what the person sets out for. The area that I thought was most interesting is pain, and there was a significant improvement in primary goal there. And I think that this comes down to two factors when toxin is used. The first is that the relief of spasticity can also relieve spasticity-related pain, but there are other qualities of the toxin, including substance P inhibition and other proteins and amines, where it can have an effect. So we may have an element of working on the neuropathic area as well. So this is all really positive for the future in terms of neuropathic pain. Studies continue in the area. Let's skip that one. Steve Bashford and his crew are also looking at arm activity measure, and this has also been quite useful in terms of looking at outcomes using toxin and therapy treatments. And this is broken up into caring for the affected arm and completing other tasks and activities. It's quite a simple tool, quite useful to use, and a good measure of treating spasticity in the upper limb in particular. If we look at the ICF domains, I just need to go back there for a second. What we do know is at level of impairment, modified Ashworth-Scale-Target and range of motion are useful in those areas. But when you're actually treating someone, that's not about their impairment, it's about their activity. Goal attainment allows us to have a good outcome measure, and self-reporting as well. And often we'll find that we don't see a huge change in the parameters that we set with patients, but they'll report that they feel much better or feel more comfortable. Things like decreased tension within the arm or the leg, more relief overnight, sleeping better, all these things come into play. One of the disappointing issues, however, is when we try and use quality of life scales, particularly when we're targeting quality of life, is they're not all that sensitive. And one of the reasons is that there are multiple areas that are questioned within these scales, but spasticity is really only targeted in a small area. And what we found when we used the AQOL, when we did the upper limb study, was that, in fact, out of the 16 parameters that we're utilising, only 4 were relevant to the spasticity. So things like ongoing depression, mood disorder, interaction with others, didn't change. So the tool really didn't meet the requirements we were looking for in terms of quality of life, even though the individuals were saying that they were feeling better for it. One of the things that's come up recently, and I'll just throw this to you now, is we know that spasticity is a dynamic process, and it's only one component of the upper motor neuron syndrome. Most of our assessments are based on passive movement, and so we're not always as accurate as we like, particularly when we're looking at associated reactions, spastic dystonias, triggering and ramping effects. And you'll see a lot of ramping effects with repeated activities. It was interesting, we recently did a workshop and we were talking about assessing upper limb and segments rather than really looking at what was happening, and we were demonstrating a patient, and in fact there was significant interaction in the segments and motor planning. And what we tend to do is measure in segments, but the actual functioning is occurring at multiple levels. So we tend to miss it there as well. Overall, what we're trying to do is measure functional performance. So we need to try and be consistent in what we're assessing to meet this. So we need to measure function. So where are we going? Probably the gold standard in terms of measurement in spasticity is gait labs, 3D motion analysis. Involves detailed analysis. We can start to use it in the upper limb now. We're becoming better at it. It's particularly effective in lower limb, and you've all seen various studies there. The issue with it is expensive and it's lab-based, and it's generally in the research setting now. What we're starting to think about doing is video-based movement analysis. It's cheap and it's accessible, but the problem is it's not standardised and it's unreliable. And we're also starting to look at kinetics with movement analysis, and gimmicks, things that we thought were gimmicks in the past are now becoming quite useful, such as Wii boards and like. They're cheap, they're accessible, but once again, they're not standardised, and we're not sure of their reliability. If we look at 3D motion analysis, its strengths are it's dynamic and task-based, it can be objective and reliable, gives us accurate outcome measurement, and it's a diagnostic tool. But its limitations are expensive, it's laboratory-based, we're still working on upper limb models, and it requires specialist training. The area of excitement is commercial game and game console data capturing devices such as the Wii and PlayStation now with PlayStation 4. These are strong in terms of their dynamics, they're less expensive, and they're portable, which is fantastic. But we've got the challenge of seeing if we can see if there's a validity for them, and we need to move away from it's not just a gimmick or a child. We can use this in a developmental way. But there's certainly some good work going on around this, and hopefully over the next few years we'll find some areas which will change the way we practice, because these being portable, we can take them out into the community and it can give us even more accurate readings on what we're attempting to achieve. So, what are the key components of physical therapy? Well, we've talked about assessment already. It needs to be accurate, it needs to be appropriate, and it needs to be targeted to the person. We need to carefully measure, record, and keep good records, and then we look at our intervention with the physical therapy or if we're going down the medical pathway. We need to evaluate what we do, because this allows us to revisit where we're at, what we've achieved, and also educate. Within the management process, the goals need to be accurate and appropriate, and achievable. There's no point telling someone to go and they're going to manage to run a marathon when they can barely walk 15 metres. It's important that the goals are set for that person's needs and are achievable. The process needs to be structured and stepwise. It's a dynamic process. Once we achieve one set of goals, a new set of goals may appear, and we need to be sensitive to that. And it's clearly a multidisciplinary approach. That includes therapists, patient, carers, doctors, or whoever's involved in the well-being of that person. I've attached to the circulation the two consensus statements on upper limb and lower limb hypertonicity, and it's worth reading those because basically at the end of the day, for all the information that we have out there, they're consensus statements. So the John Oliver paper is lower limb and the Jeffrey Sheen paper is upper limb. They're worth reading. Gives you some good background of where we're going. It's a starting point for where we're moving forward. Main issues. We have class 1 evidence for spasticity. So we know that if we treat spasticity with therapy and with medication, we can improve it. But all we're doing there is working at the impairment level. For functional gain, we don't have class 1 evidence at this point in time. There's better evidence for passive functional goals, and most of the early research was done in hospital settings, looking at passive goals, which were a lot easier to measure. Our evidence for active functional goals is low, but the evidence is emerging. And this is what we really need to target over the next 5 to 10 years to justify what we're doing. If we look at therapy interventions, the types of therapy that are done are very broad, and we're not quite clear what everyone's doing. There's certainly some evidence that if we target down into dedicated spasticity management protocols, we're getting some more consistency. When we look at the studies, it becomes quite heterogeneous, so it's difficult to compare study from study, and as such, things are poorly defined. However, what we do know is if we know we've got a treatment that can help someone, it's unethical to restrict this treatment from that person. We also have to be aware that other independent activities may impact upon the person's response as well. And if you remember early on, I talked about cognitive issues, social issues and like that may impact upon a person's well-being and the outcomes in terms of their spasticity management. At this stage, in terms of management of the upper limb, with the lower limb, there is some good evidence now to with using gait lab studies that we're starting to get some change. But with both, we still are struggling to have a lot of evidence to support or refute what we're doing. As mentioned about before, research is really towards passive indications, but our therapy is actually towards active indications and therapies because that's really what we're targeting is a person's function. What's critical now is we do need to consider if we are looking at active indications, we need to consider dynamic assessment. Within our management, we need to understand the concepts of neuroplasticity, looking at motor control and motor skill acquisition, remembering about repetition, task practice, changing the engram. Animal models that have been shown to be functional task specific are now trying to be translated into human models, but we have a huge variation within our functional parameters. So the types of physical therapy treatment that we can consider are preventative and provocative factors, looking at postural management program, positioning setting as we mentioned before, stretching programs, active physical therapy with neuromodulation, neurofacilitation alike, and casting and splinting. And I'm happy for the therapist to expand on that for me shortly. If we consider provocative factors, we need to remember issues that may increase tone, and that's the column on the left, noxious stimuli. Fatigue is such a debilitating process, and it's often the first sign. Spasticity change is often the first sign of fatigue because it's such a stealthy way of things occurring. You can also increase your spasticity by rapid movement, bladder and bowel dysfunction, fear and anxiety. Watching that horrible doctor walk in the room first thing in the morning can make the person feel quite uncomfortable. If you're gentle with your tone of voice and you provide a milieu that's comforting for the person, you'll often find that the person copes much better than when you're aggressive and inconsiderate. Hot and cold can also have an effect. You want to make sure, if you're trying to reduce tone, that you put a good milieu there for the person, remembering other medications that they could be taking may affect things as well. That's a fairly straightforward slide. Seating's really, really important. We tend to underestimate it, but if we don't, particularly in spinal cases, for example, if we don't address bony prominences and like, we can set up the noxious stimulus. We need to look at appropriate chairs, safety environment, footrest where appropriate, static planning, and therapists do this better than me. So for the doctors out there, get your occupational therapist or your physiotherapist involved. Who does the wheelchairs here, guys? Both. It's a two, but praise. Good answer. Okay. So what are we targeting? Muscle length, strengthening, and functional performance. We need to involve biomechanical, cognitive, and neurophysiological techniques. The concept of getting the patient to feel that they're making the decisions often helps, even though you make them for them. That's called covert dominance. But you need to understand that physical therapy can't work alone. We need to look at those neurophysiological techniques and cognitive behavioural issues. And these can be used in with other treatments for spasticity management. Stretching is really to promote outside therapy time. And you'll see a lot of patients who are actually constantly stretching because they're being well trained by their therapy staff. So habituation or adaptation of the stretch reflex can occur with repeated stretching. And where you've got the more significant issues with spasticity and contracture, splitting and serial casting are quite useful. You target the tonic stretch reflex for decreasing the muscle tone. You increase the length of the musculocutaneous unit, and you try and remove noxious stimuli. And particularly, you need to be aware that if you are casting or splinting, that you're not creating pain, because this will reverse what you're trying to achieve. It's not meant to be a supportive situation, but to maintain stretch and increase length. I might just stop for a second before we go into the medical model. Does anyone have any comments about therapy interventions, what they've found useful recently? I'd like some involvement there, because people do things in different ways, and it'd be pleasing to hear if someone's found something that's been of use of recent times. Any comments? I won't change my scene here. Hello, has anyone got any comments? Any questions so far?
I have a question about
Yep.
when you refer to...
Can you identify yourself and speak up, please?
This is Rosalind Moser from Newcastle, New South Wales.
Oh, hello, Rosalind.
I just had a question, hopefully some clarification about early intervention. Are you using the term early based on when the initial injury occurred, or when you start seeing the negative effects of increased tone?
Okay, that's a good question. Essentially, early intervention means when you're seeing some evidence of hypertonicity or spasticity. It may well be that you're not trying to dampen it, but you may be trying to utilise it. I think that it's important to understand that if you can prevent the negative aspects of the spasticity early, it's important to do that. One of the challenges is when is the right time to introduce more aggressive therapies, and that really depends on the individual. But I would suggest that when we're talking about early intervention, we're even talking about promoting the spasticity as good spasticity or good hypertonicity rather than trying to prevent spasticity, because in certain situations it may be of benefit. Does that answer the question?
Yes, it does. Thank you.
One of the difficulties is that we don't have a lot of good evidence before 3 months. But we certainly know in those situations where someone's had a significant head injury or intracerebral event where there's rapid evolution of spasticity, there's a role for even using botulinum toxin in intensive care. It's an interesting process when you try to do that, because you get told that you're using an expensive drug and it doesn't fit the budget. Yet what you're trying to do is prevent contractures, pressure areas and like. So we're trying to work our way into that area.
I've trained in the United States and some experience with using the botulinum toxin in the ICU. One of the things that I did note was that the person usually became less distracted, maybe could attend a bit more to some other interventions. So I did find it helpful.
Absolutely, because what you're probably finding there is with their spasticity, they're getting pain, pressure points and like. So their resilience is less as it is, and if you can dampen down those effects, it does allow for them to be able to cope with their situation a little more comfortably. Any other questions or comments? I shall move on. Do we need time to mute everyone? Okay, let's have a quick look at the medical options for spasticity. What we tend to focus on really in terms of our practices, principally focal spasticity, to a lesser extent regional spasticity, and to even lesser extent generalised spasticity. Particularly in the world of botulinum toxin, we're talking about focal spasticity. But we need to be aware that spasticity can appear in a number of ways. When we look at the medical management, most of the oral agents are quite disappointing. We do know that baclofen is quite useful below the blood-brain barrier, and is more effective in spinal spasticity than it is in cerebral spasticity. It's a GABA B receptor stimulant, and it suppresses the excitatory release at the presynaptic region. This is so it's quite effective, particularly at the spinal level. Diazepam, you'll see it used particularly in acute hospitals. It's a GABA A receptor stimulant, tends to relax everything. I think the major use for it is that the neurosurgeon doesn't get awoken at night. It's a long-acting medication that has significant central effects, and it should be avoided at all costs in this sort of patient, particularly if they're becoming mobile or they're cognitively blunted. Tizanidine is an alpha-2 agonist, has similar properties to baclofen. We don't tend to use it much here. It's an S100 medication. Dantrolene is quite useful for generalised spasticity as it works at the calcium channel. The issue with it is that if you're using it in a hemiparetic situation, it dampens down all muscles, not just the hemiparetic region. So it can have a generalised weakening of the person and have issues with fatigue as well. There's some good studies now discussed in terms of anesthesia medications. There's been some good work by Bagley in the use of pregabalin in limiting the escalation of spasticity, so that's been utilised. There's some studies with gabapentin as well. And clonidine is occasionally used as an alpha-2 agonist as well, but I tend to avoid that because of hypertensive issues. In terms of local management, botulinum toxin A is the gold standard. Phenol may be used for larger local and more regional issues. It's a neurolytic agent and is very effective, but it doesn't differentiate between sensory and motor fibres, and dysesthesia is a common side effect. It lasts for more than 6 months and it denatures the protein around the nerve itself. It's good for obturator nerve blocks, suprascapular blocks, occasional femoral blocks. Lignocaine and ethanol really aren't utilised all that much now. So, and the reason is that they've been well and truly overtaken by botulinum toxin, which works at the presynaptic nerve terminal, preventing acetylcholine release, so muscle becomes functionally denervated. So it's not a true nerve block, it works at the neuromuscular junction. We'll show that up shortly. Where you've got refractory spinal spasticity, particularly regional and some general, you may have a role for intrathecal pump. Phenol's not used here anymore because of significant side effects, but you may see a combination of baclofen and morphine. The advantage of using baclofen in the pump is you use much smaller doses and you can get to the GABA receptors more efficiently, so it's very effective in spinal patients. If things aren't working out all that well, you may well consider neurosurgical techniques. These should be considered more as a definitive process and after failed conservative management. You may try neurotomies or rhizotomies for regional aspects. Occasionally neurostimulation may be utilised in the brainstem. And in orthopaedic situations, tendon transfers and releases can be tried, or contracture lengthening can be tried. One of the issues with tendon transfers, though, is if you are considering botulinum toxin treatment, you can change the processes if the patient's gone through tendon transfers originally. You also have to remember that when you're undertaking tendon transfers or releases or contracture lengthening, you're not treating the original problem or the main problem, which is a neural-based issue. Occasionally, surgeons will take it to the point where they'll look at arthrodeses, particularly around the ankle. The issue, however, is the tendons bypass the ankle and you still can have issues distally and proximally to the fusion. So if we look at this slide, this was a lovely slide provided to me by Clemens Fedorov of where we can target spasticity in a whole range of ways. I want you to make sure you look up at the right hand side because that talks about care, physiotherapy, occupational therapy management, reducing harmful input, and modifying and stabilising any underlying disease, because they're the first things that we should be doing. Then we can look at the medication processes. But there are a number of places all along the watchtower, for want of a better expression, where we can target. The critical thing is that we're adapting and compensating, we're not curing. We need to remember that. Any questions on that? I apologise for my voice. No questions? Okay. Now we'll have a little stroll through where botulinum toxin fits in for focal spasticity. History. All goes back to the 18th century. Justinus Kerner was a German physician and poet, and what you'll need to know is that physicians in those days usually had another bow to their activity levels, because medicine was more of an art than a science in those days. And botulinum was first noted, or botulism was first noted at this time. There was a little delicatessen in a little German village, and patients became paralysed associated with badly handled meat products, and the phrase sausage poison was coined. Kerner had a mate, Muller, who was a physician and artist, and he coined the phrase botulism because botulus was Latin for sausage, so that's where the term botulinum toxin comes from. In 1895, we first isolated the bacterium Clostridium botulinum. 1944 was cultured during germ warfare, and then in 1949, it was discovered that the toxin blocked neuromuscular transmission. During the 1950s, multiple episodes of research were undertaken. This was usually done in animal models, and it was really noted that overactive muscles did respond to the toxin to decrease the muscle activity. It was in the late 70s, early 80s that the human factor came into play. Scott was an ophthalmologist in the States, and he noted that while he was treating strabismus, which is muscle activity around the eye, that people's crow's feet and facial frowns were disappearing, and hence the wonderful world of plastic surgery and like, where botulinum toxin became used in aesthetic processes. But what also tended to happen was that the evolution was that muscle relaxation was found to be useful in other ways, and then we discovered that it was useful in neurological conditions such as spasticity. And in that time, since we started treating upper limbs for spasticity, noticing dysphonia and dysphagia, and lower limbs for spasticity, noticing bladder and bowel control issues, the toxins become useful in many other ways. It's now used in spastic dysphonia, dysphagia, gastroesophageal reflux, hypersalivation. Then if we go downstairs, hyperactive bladder, rectal spasm, bowel spasm. So there's a whole range of uses. Don't forget, we're also using it now for sweating and like. It's becoming quite a quite diverse tool. The other area which we've sort of touched on is the use in pain, where it has other activities beyond the neuromuscular junction, and we're seeing some effects in chronic pain situations. The studies still are limited there. I have to tell you that this slide is now out of date because there are serotypes A to H. So we've recently discovered an H, botulinum toxin H. We're not sure of the properties yet, but there are different serotypes that work under different anaerobic conditions. They have common features, 20 amino acids in their proteins, similar molecular weight, a di chain subunit structure, and 2 heavy chains. And these chains are separated by the action of trypsin. So how does it work? Neuromuscular junction blockade. So it's taken up at the presynaptic nerve terminal, cleaves acetylcholine vesicle binding proteins called snare proteins, and this prevents the acetylcholine vesicle binding to the presynaptic membrane and releasing the acetylcholine. So the muscle is functionally denervated. Schematically, if you look here, the nice big round circle is the synaptic vesicle. The snake-like structures are the snare proteins. These are attached to the vesicle, cause a fusion complex, and the neurotransmitter is released. So we get the fusion occurring here, and the neurotransmitter is released. I forgot about that. Use of botulinum toxin. It's endocytosed. It cleaves the snare proteins, so they're not able to be their snake-like characters. They can't fuse with the vesicle, and we don't have the fusion at the membrane, so we don't get release of the neurotransmitter. So we don't get excitation and contraction. So the muscle fiber remains relaxed. The various toxins work at different areas. Hello. Okay. A and E work at SNAP 25. feed works synaptic rhythm. I'm getting echo here.
Yeah, sorry, I'm just going to mute one more second.
Of the toxins there, only A and B have been found for clinical significance. What's the rationale for treatment? Are we able to get rid of that echo?
Yep, give me 1 second. My screen isn't refreshing. It's taking too long. Sorry about that. Hi, sorry, just disconnected. Can you disconnect, please?
Okay, rationale for clinical use of botulinum toxin? Simple. We treat the conditions featuring focal muscular hyperactivity by producing temporary focal, selective and greater muscular weakness without adverse central nervous system effects or risk of sensory fibre injury. So it's focal spasticity management. So we consider using it in focal spasticity where there's pain, restriction of movement or excessive and inappropriate movement. It should not be used to improve power. That's not what it does. It actually weakens or decreases the activity in the muscles that you treat. However, that will allow you to target the antagonists and try and build them up. So it gives a window of opportunity working with those muscles. And we're seeing this occur also in its use in dystonia now, where we're trying to target antagonists in dystonia with some effect beyond the previous just injecting and moving along. It fits in the classification of reversible because it lasts for about 3 months and wears off in its pure chemical sense, and treatment of focal spasticity. You'll tend to use oral therapy and intrathecal baclofen in general and reversible situations, rhizotomy or surgical in situations in more permanent areas. Okay. Advantages of botulinum toxin A. Focal selected graded effects. No CNS side effects. So it's amazing the number of patients we've injected over the years who have come out of the situation feeling incredibly well without any ill effects. It works independently of the pathophysiology of the mechanism of motor activity by working at the neuromuscular junction. There's no sensory disturbance. It's non-destructive, it's a closed procedure. When I started doing this 20 years ago, we gowned and gloved and it was like an operation. Now we tend to wear gloves and use aseptic techniques more for our protection than the patient's protection because it's a really safe procedure. What we do know is this weakness will resolve spontaneously, which when associated with a toxin. However, you do have to wait at least 3 months, and that's a challenge in itself. And the process is really safe and well tolerated. I've had probably 1 significant complication in 20 years. Disadvantages is that its effects only last 3 to 4 months, so you do require repeated injections in a number of situations. Let me say, in combination with appropriate therapy, we're finding we're not injecting people more than every 6 months. There are occasionally patients who require repeated injections on the 3-month mark, but they tend to have a more dystonic component to their pain, which is interesting. So in combination with therapy, we're getting longer and better outcomes. Its effects are non-reversible during the period of action, so if we do get effects that we don't want, so we overtreat the spasticity or the spasticity that we've treated as being good spasticity and we have a worse functional outcome, it will reverse, but we have to wait the time duration of the injection. The injection can be painful, particularly depending on the injector and the technique and the size of the needle, but a lot of patients actually don't even feel anything at all. It's interesting, particularly in the stroke group where we're thinking we're treating just a pure motor stroke, that in fact they may have some sensory dysfunction as well, and so it's not that uncomfortable. I have been in a situation where I've injected someone in a demonstration, the patient's basically fallen asleep while I've injected them. Then we've woken them up at the end of the injection sequence, and they've told me to get on with it. So it can actually be well tolerated. We do have a limited maximal dose. This is relatively arbitrary. Some of us have used doses beyond what's recommended without ill effect, but that needs to be done in a fairly careful, controlled situation. You may require EMG, nerve stimulator, or ultrasound guidance. I always utilise a nerve stimulator. Colleagues utilise ultrasound guidance. There's certainly good evidence to show if you try and do it just on an anatomical delineation that the risk of missing is much higher and the outcomes are much poorer. There is a cost associated with using the toxin. The only group at present who are adequately funded are those of post-stroke upper limb spasticity, and even they are only limited to 4 injections in a lifetime. And there is the potential for clinical resistance due to antibodies. This is extremely rare, extremely rare. Adverse effects: you may overtreat and have reduced function. You may get unintentional weakness of adjacent muscles where there's been spread of the toxin. You may get local pain or hematoma. I've really not seen that, although you do have to be careful, particularly in patients who are on anticoagulation. There is the universally documented flu-like illness that I'm yet to see. You may get a neuralgic amyotrophic-like illness, and I have seen that once, and long-term secondary clinical resistance, which is quite rare. I think I've had 1 or 2 cases at best. Precautions and contraindications: hypersensitivity to any of the components of the makeup of the toxin, infection at the site of the proposed injection, other neurological conditions, particularly those that may have a lower motor neuron component, such as motor neuron disease, myasthenia gravis, Eaton-Lambert syndrome. Aminoglycoside antibiotic use may interfere with not only the toxin, but there may be ramping up the aminoglycoside activity as well. Where you've got established contractures with no spasticity, there isn't a role. That's fixed contractures. But if there is a contracture with spasticity around it, then treatment of spasticity allows for better management of the contracture. And certainly don't recommend it in pregnancy or lactation. There's no research evidence for or against it, but you just wouldn't take the risk. In terms of patient selection for botulinum toxin, absolute contraindications, no meaningful goals. If the patient just wants to have the toxin because it sounds like a good idea, then you really shouldn't go there. If the expectations are unrealistic, then you really need to spend some time looking at goal setting before you go down that pathway. It's an expensive process if the patient isn't prepared to comply with post-injection treatment protocols. Then clearly you're not going to get the best benefit that you want, and you leave yourself open for lack of success. And you also need to make sure that there's enough support around the person. Relative contraindications may be access to multidisciplinary service for post-injection therapy interventions, but if there are experienced therapists in the community who can be utilised, that's a terrible term I should say, there are experienced therapists in the community who may be able to provide excellent service and assist with the management of the patient. And as I mentioned before, fixed contracture where there's no significant target. We do talk about using electrical stimulation, electromyography or ultrasound to locate particularly smaller, deeper muscles. I would avoid the second area now where we're using palpation and looking at the needle moving, because you may well be in a fascial plane between the muscle fibres and you're not targeting the area as well as you should. What we do know is that end-plate zones may be of use, and we're starting to change our idea of where we inject in muscles. Often we inject a little more distally than the classic sites because there tends to be a gathering of motor endpoints and motor junctions there. We do know, however, that spread of botulinum toxin injection occurs within the muscle itself. We encourage patients to be as active as possible to spread the toxin, and also larger volumes may assist with this as well, larger volumes of diluent. In Australia, there are only two available botulinum toxin preparations. One is Dysport, which is the European model put out by Ipsen, and the other is Botox, which is the more commonly known, which is the US model, which is put out by Allergan. They are not interchangeable as the dosages are presentations are different, and we have maximum recommended dosages for each, with Dysport 1,000 units and Botox 400 units. The ratio is somewhere between 1 and 2.5 to 3 in terms of 1 unit of Botox to 2.5 to 3 units of Dysport for equivalence. Two other forms of botulinum toxin are available. Xarelto, which is modelled on Botox and is made by a German company, and there's a Chinese form of botulinum toxin A, which is supposed to be more effective and more have better outcomes, but we've never seen any evidence for it, and we're still waiting. It's meant to be a more wild variety. Just gives you an idea that we have ranges of dosage. As much as it's a science is also a bit of art in terms of what we're targeting. We need to look at what we're trying to achieve when we're injecting the toxin. We try and spread the dosage as evenly as possible through the area we're injecting to get the best result for the person. Common muscles injected: biceps, brachialis. The red dots are really where we injected the sites: brachioradialis, pronator teres, flexor carpi radialis ulnaris, flexor digitorum superficialis, and profundus in the upper limb. Lower limb: rectus femoris, iliopsoas, adductor longus, biceps femoris, gastrocnemius, soleus, tibialis posterior, and flexor digitorum longus. We need to understand how these muscles work, what their activities are, and their influence on the movement patterns of the person when we're targeting the injections. What's the rationale behind delivering combined treatment? Botulinum toxin is really targeting the hyperexcitability and the loss of long latency reflexes, and at the same time you're having issues with loss of supraspinal drive, muscle function, and altered mechanical properties, and this is where the therapy targets, and they work in combination to target the spastic movement disorder. So when we consider best responders, the function targets are passive function, active function, pain, and associated reactions. Who are the best responders? Well, what we need to consider here are established spasticity patterns, no fixed contraction, appropriate goal setting, then commitment to follow-up physical therapies and self-management, the ability to review and adjust the goals of physical therapy. And if you are using toxin, there are no contraindications to it. And they're the critical things you have to tick off if you're considering botulinum toxin in the management of a person. And I go to point 4, it is so important that there needs to be commitment to the follow-up in terms of the physical therapy and what's done at home as well. So in terms of the post-injection management, we encourage immediate activity. I think of a patient I had where I do upper limb management now. She's a delightful lady. She'd previously been seeing someone else, and she was having light anaesthetics and light general anaesthetic to have her upper limb injections. But it would take her 3 to 4 days to get over the process. And she came and saw me, and I refused to use general anaesthetics in adults. I can understand the use in children. My belief is that generally, if you're presenting with an upper motor neuron syndrome, you've had some neurological damage as it is. If you're providing an anaesthetic which can have central dampening effects, you may be compounding the problem rather than assisting the problem. With this little lady, I had a terrified individual for the first time I injected her. The process wasn't as bad as she thought it would be. I've injected her a number of times now, and we've got much better results than when she was having the anaesthetic, because we could actually target what we're trying to achieve. Makes a huge difference. So we encourage immediate activity. The patient can be involved in this. They can do their stretching, their facilitation, their walking. You can trial electrical stimulation. Try and facilitate activity in opposite muscles. Get them involved in their management. If necessary, look at early splinting, serial casting, and reviewing this every week, minimising pressure area, trying to get the contractures out further. And it's important to follow up within 4 to 6 weeks if you do inject, to make sure that your treatment goals, if they're not being achieved, they're on the pathway to being achieved. And always review it in 3 or 4 months to review to see whether you need to intervene again with a toxin. But within this process, there should be the ongoing multidisciplinary management. Okay, we might stop now and have a bit of a chat, if possible, because that's most of the content of the discussion today. That's an hour and a half of my voice, which is starting to tire. So can we have a few questions and comments? I might minimise this for a bit, if that's okay. Nina, is that okay?
Yeah, that's fine, no problem.
Okay, let's have a look. And we might see some faces. There's a face or two. Any questions?
Steve, it's Gary Pierce.
Hello, Gary.
Steve, you haven't embraced ultrasound. Is there a reason for that, really?
Me in terms of injection?
Yes.
I know I do a little, but I tend to prefer to use electrical stimulation. But it's often more about time frames. I use it a little in particularly more complex situations. Barry Rewicki uses it religiously. John Oliver uses it intermittently. I use it a little less than intermittently. But it's more about my comfort zone with what I utilise, Gary.
Thanks, Steve.
It's a good, but in terms, if you actually want to be precise in where you're injecting, it's the gold standard. Are you using it at all?
I was. I'm not actually doing it at the moment. But when I was working in Hobart, we were using it.
Yeah, it's a very good tool. I would say I underutilise it. And I would encourage people to use it if they are injecting.
Is there any
physical therapy? Sorry.
Is there any chance that the Medicare rules will change in the near future?
I'm not a politician. I think probably, you mean in terms of PBS and funding?
Yeah, sorry, PBS, yes.
Yes. There's a big lower limb study going on at the moment. The potential is much greater with that. I think that down the track, yes, because the PBS were really scared that there would be a flood of use of botulinum toxin for anything, and it just didn't happen. And I think that that's a feather in the cap of all of us, because we're using it judiciously. We're not using it for anything and everything. When we did apply to the PBS, they were worried about the dollar. When we came to them and said, look, we can improve spasticity, they said, we're not interested in that. We want to know that function improves, and we want to know that there's a quality of life improvement, and we want to know that we're getting value for our money. And for some reason, the number 4 came up, and that's why they limited it to 4. Hopefully, when we get the lower limb study out and we get the results of that, we'll be able to expand, because it does restrict people who can't afford it.
Thank you.
Hi, Dr. de Graaff. Sorry to interrupt. Are you able to stop sharing your screen so that we can see everyone clearer?
Oh, I'm not blocking you, am I? Okay, I will get rid of that. I apologise.
That's okay.
Yes.
Except I've got there we are. Is that better? It's just I can't see anybody in my ears.
No, that's fine. It will take 1 second.
Yep, I've got rid of it.
So you've stopped sharing, have you? Okay.
Yep.
Maybe just click on that. Does it still have a play sign in there?
Oh, hang on, sorry. I'll do one more thing. Does that help? Is that better?
There's a bit of a delay. So if you can click the arrow on the share, unless you're going to be, are you presenting still, or are you wanting to get rid of your screen?
I'm probably not going to present anymore. I think that I was hoping some people might bring up some case studies to discuss.
Sure.
If you just select that drop-down arrow in the share function.
I'll have to minimise again. I'll go back. So I've got to go into the share there.
Drop-down arrow, then select stop sharing.
Hang on, I'm missing that. Video desktop, where's the drop-down arrow? Oh, you stop sharing? Yep. I'll select stop sharing. Done.
Perfect.
Now I'll go. Now, if I go back to mine, oh, there's a dog. Is that better?
That's fantastic.
Has the dog got a question? Or does it need to be fed? Has anyone got any questions?
Dr. de Graaff, this is Rosalind from Newcastle again.
Hello, Rosalind.
I was wondering, are you using any assessments via telehealth for following a patient?
I have on 1 or 2 occasions for follow-up, and it's actually been very useful. Particularly for country patients. And that's it. I've also used it on 1 or 2 occasions where someone's been actually in a hospital in another state, and we've looked at trying to plan some management as well. So it actually, it's not as good as being there, but it's a hell of a lot better than doing it over the phone, and it really does allow for some interaction.
Did it require that you train the family or some carer before you did that teleconference, or was it just cold?
It was cold, but we were able to have the family involved and take on some management strategies from there.
Thank you.
So it opened up communication, and the family actually really appreciated it because of the difficulties, obviously, of support. Any other questions or comments?
There are still 24 people connected in, Dr. de Graaff, so they are out there.
Yeah, I can't see them. Are people happy for me to run through 1 or 2 case studies I've got here, which were done for a different reason, but they're actually quite useful in terms of talking. They're upper limb based, but we can sort of run through them a little, if people are happy to do that.
Yeah, that would be good.
Okay. First case study. We've got an 82-year-old gentleman, Mr. TS. He's got a history of hypertension and atrial fibrillation, was on warfarin. He was actually a retired ophthalmologist, was a very bright man, had the most delightful wife. He unfortunately sustained a left cortical infarct in 2001 with a residual right hemiparesis and expressive dysphasia. And the dysphasia did make the challenge of managing his spasticity, as well as his general well-being, a little more challenging. At the time of presentation, he was wheelchair dependent, and the carer propelled the wheelchair. He was moderate assistance in all his transfers, and because of his non-functional right upper limb, and he was previously right dominant, he was full assistance in his self-care, essentially. He could follow 4-stage commands, but his verbal output was quite poor. His affect was a bit flattened, and it was his wife, who was getting on in age, who was his principal carer. The reported problems were his non-functional right upper limb, with a clenched hand, with deteriorated skin condition, poor access to fingernails, and unsuccessful donning of splint overnight and later in the day. So what I mean by overnight is late in the day. And he was having problems with his transfers. When we looked at his clinical situation, there was no active movement in his right upper limb. He certainly had some maceration in his right hand and poor nail quality. His transfers were an effortful, including me, one-person transfer assist. His MAS, or his modified Ashworth score, and we're doing this because this was for a botulinum toxin presentation. It was really quite tight at the wrist and fingers and quite stiff at the shoulder and elbow. There were no dystonic movements or associated reactions. And interestingly, he didn't have significant pain even with stretching his finger flexors, which were really tight. His goals were to open his hand normally, no longer need to splint, and get out of the wheelchair alone. His wife's goals were improve fingernail and hand care, improve visa transfers, and decrease his pain that he wasn't reporting, but he actually had. So that was a good one in terms of looking at the patient and their carer and seeing what you could try and achieve. So the questions we ask in this situation are: what are the problems best targeted? What are the achievable goals that can be set? In terms of botulinum toxin, does he meet? Is there a role for botulinum toxin? Does he meet the PVS criteria? Can botulinum toxin assist with achieving the goals? What should we target? And what follow-up is appropriate? Okay. So I don't give you answers there, we'll talk about it. So, firstly, open for discussion. What do people think about the patient's goals?
Hi, sorry, just give me 1 second while I unmute everyone.
Sorry, can you just run through the patient goals again?
Okay, I'll put it back on the slide there. Patient goals are to open the hand normally, no longer need a splint, and get out of the wheelchair alone. The wife's goals were improving fingernail and hand care, improve visa transfers, and decrease his pain, which he didn't report. Do you think the patient's goals are achievable?
Maybe 1 and 2, possibly not the third.
Okay. I'd like to say I'd like to see hands, but I can't. Okay. This guy's had a non-functional right upper limb for 8 years at the time of this presentation. So there's been no active movement in the right upper limb. He's certainly got poor control proximally, which is a negative prognostic feature. Interestingly, when you talk to his wife, she can actually open his hand much more easily first thing in the morning when he first wakes up. This is not an uncommon feature in post-stroke spasticity. one of the critical things about it is often patients will come and see you in the clinic mid-afternoon, late afternoon. They've been pushed into a taxi, which is driven at 150 miles per hour in a 60-kilometre zone. They've been hauled out of the taxi. They get thrown into a wheelchair that's got a wobbly wheel. They get wheeled into your room, and their arms sitting up above their head. And everyone says they've got a contracture. It's really important to ask what the hand's like first thing in the morning, because that's the state of least noxious stimulation, and it gives us an idea of what can be achieved. In his situation, when you see him in the clinic, his hand's really quite tight, and you can pull it open, but it's really quite a battle. When I was talking to his wife, she would say that she'd try and do things with his hand first thing in the morning because the hand was a lot less tense. So that would be an indication for me that there's clearly a overactivity, and there's, in terms of the hand goals, we certainly could improve his fingernail and hand care, which is a burden of care issue, by the use of toxin. His concept of opening his hand normally needs to be clarified. Does he mean himself in terms of active opening, or does he mean passive opening? Now, active opening I don't believe is achievable. Passive opening may be achievable. So it's a bit of a, you've got to tease out what you really mean there. His concept was opening it himself actively. We gradually worked him through the theory that, or the plan that it would be about him being able to open it with his left hand in a more comfortable way. The second thing was about wearing the splint. He hated the splint, and it was uncomfortable, particularly when his spasticity or overactivity became problematic, and it would disturb him at night. They had trouble getting the splint on, and he'd often want to get it taken off first thing at night. So it wasn't an unreasonable goal to attempt to have a situation where he didn't need the splint all the time. No longer needing the splint was probably a bigger challenge, but it was worth considering. His next goal was to get out of the wheelchair alone. His wife's goal was to improve ease of transfers. One of the issues that happens when you have increased flexor tone in the upper limb is that you throw your centre of gravity out. Tone in one area also acts as a noxious stimulus for another area. So certainly the goal of improving ease of transfers makes a lot of sense. But we thought it'd be interesting to see if we could get him to a level where he could get out of the wheelchair alone. And the third goal that the wife has was to decrease his pain or discomfort when she was cleaning his hand by stretching the tendons and that. So that was probably achievable as well. So the goals are achievable to a certain extent when you tease them out. So we actually did, I actually injected him on several occasions botulinum toxin, and the first thing to say was hand care improved enormously. We lost the macerated skin, the nails were well cared for. So that passive goal was easily achieved. He was able to at times open up his hand with his other hand, so it was a passive role, but him doing it himself. And he wasn't needing the splint generally during the duration of the use of the toxin, and that was often a good sign that we were starting to think about needing a toxin again. The other critical thing that happened with Mr. TS or Dr. TS was that, in fact, with his arm, we'd also treated above the elbow, and with his arm dropping down for mobility, he actually got to the point where he was able to transfer himself in and out of his chair himself. He needed, over longer distances, still to use the wheelchair and have his wife pushing it. But in terms of getting in and out of the wheelchair, with the dropping of his arm, his centre of gravity came back more towards the midline. He had, interestingly, less tone in his lower limb, so he was able to achieve transfers himself for a period of time. When his transfers started going off again, that was also a sign. And in terms of the pain goal, that was achieved because the less tension in his forearm flexors, his wife was able to open his hand more easily and take care of the hygiene there. So the goals were achievable. There was a role for botulinum toxin. It was specifically targeted. I've overlooked the other critical factor here, which was he was having outpatient therapy as well, the team here, and carrying on a home exercise program, which included stretches and ranging. And this not only helped him, but it helped his wife because she felt supported in the whole process as well. Any questions on that? Does that sort of make sense in what we targeted?
How long did the therapy continue? Was it for the 4 to 6 weeks post-injection, or?
He had therapy for about 6 to 8 weeks, once or twice a week, plus his home program, and then he continued with his home program. And his wife was quite good at structuring to make sure that he did it. So that's really important that the carer is involved. But that was critical as well because that got him into good habits. And the fact was, each time we injected him after that, he did a little better. Other questions? Comments? Anyone had similar situations? We could look at a late intervention type patient. And this is Mr. TC. Smile in the background here. Very interesting character. Pontocerebellar hematoma, collapsed while playing a game of football. Was left with residual left-sided spasticity. Worked as a secondary school teacher, even within his limitations. Prior to his stroke, he in fact just missed out on making the Olympic athletic team. So he was a very active gentleman. He was first seen over a decade after, 31 years after his stroke. Now, the way he got to me is an interesting thing. Doctors don't refer for spasticity management. Physiotherapists, occupational therapists and nurses refer for spasticity management. So I'd worked with an occupational therapist who, when she was in Melbourne, and she'd returned to the hometown, and she knew about this gentleman and she referred him up. Prior to that, he was told that nothing else could be done. So when we looked at him, he had significant spasticity in the left upper limb with overpronation of the forearm and elbow flexion. And he had acquired various posturing of his left ankle and foot, and very poor foot clearance on mobilising. And to this day, he still falls safely, he tells me. So we initially managed him with an inpatient multidisciplinary program, including neurofacilitation with follow-up outpatient physiotherapy close to home. So we didn't target him with toxin to start with. He was able to return to umpire in regional cricket matches, which was one of his pet loves. I'm glad I was never on the end of one of his decisions. In July 2008, he returned. He had a decrease in high-level balance, a loss of function in the left upper limb, marked spasticity around the left elbow, and hyperextension of the left knee. The quadriceps graded at 3 on a modified Ashworth scale, and toe curling at modified Ashworth scale 2. We elected to inject his arm, rectus femoris, and long toe flexors. I did a phone review with him because he was still being managed closer to home. There was a significant improvement in the positioning of his left arm with decreased discomfort, so this was successful. With the treatment of his rectus femoris, he felt unstable around the knee and he was requiring physiotherapy and close adjustment. So some of the spasticity that was in his left lower limb was actually good spasticity. Once again, he returned in 2009. Can you see me, or is it dark?
No, I can see.
Oh, good, because it's very dark in here. He's worsening left lower limb spasticity, difficult standing periods by the end of a successful cricket umpiring season, so I suspect he was giving people out earlier. We noted that his focal spasticity around his left lower limb, particularly calf group, with ankle flexion and ankle inversion both graded MAS3. So we injected his calf under electrical stimulated guides with botulinum toxin. 2 weeks later, we had him in as an inpatient, increased standing tolerance, decreased pain, able to put his foot flat on the floor, no falls, and he started mobilising the community more successfully, and he still had his physiotherapy. So the critical discussion on this guy is that he was someone who floated around for 31 years in the prime of his life, who was told there was nothing else that could be done, and we started intervening a little later, and there was a significant improvement in his quality of life. We still inject him. We've just had him in recently after injecting his upper limb for a period of inpatient management, improving both his upper limb function as well as his mobility, because when we treat his upper limb, his gait improves. He probably needs some more toxin in his lower limb at some stage. I'm always a bit cautious with him now because we did overtreat his rectus femoris and impact upon his gait stability. But he's a good example of someone that we treated later and we've had an excellent outcome. He lives in the country. On the one hand, it brings up the question, could we be doing him with telemedicine? We probably could, but he likes coming up to Melbourne and going to the footy at to see Essendon play. So it's actually, he comes up and catches up with his family up here, so we tend to treat him up here, but we do discuss with his local treaters. But he would be a good candidate down the track to consider tele rehab. All right. I'll let just a couple, if there are questions or comments, I'd like to wind up in the next couple of minutes because the team here have got another project on after this. Are there any comments, any questions, any discussion? How many have we got left online?
We've actually still got 19 participants. However, there are a lot of them that can't interact because they didn't have microphones or cameras. So.
Oh, okay. Yeah. Okay. Gotcha.
Too many questions.
Gotcha. Yeah. Yes, Roslyn.
Besides distance in that gentleman, was there any other reason to admit him for an inpatient stay? Was there anything about his care that made you a bit more concerned that you prefer treating him?
Yeah, his falls.
Okay.
His falls principally. And one would have to say that he's a little disinhibited or a little on the edge at times in terms of activity, so it's actually quite useful to just target him for a bit. The other thing it does do is he's got a lovely wife, but he's a bit hypomanic, so it gives her a break for a week or so, and she recharges her batteries as well. So it helps the whole package.
Good, thank you.
If there are no more questions, it's 5 to 6. I think we might let people go home, Nina. What do you think?
Sure, that's your call. I don't know if you wanted to give your email out if people had questions, but that's entirely up to you.
I'm happy to give my email out. Steve, well, a couple of things. Firstly, I can always be contacted through the Australasian Faculty of Rehab Medicine. I'm president and present, so the office has my details. And Steve de Graaff, DEGRAAFF, at epworth.org.au.
Excellent. So we will be uploading this webcast to our website. We have sent the link out. Please get in contact with myself, Nina, at RHCP events, and I will be able to give you more directions as to how to have access to that. Thank you very much, Dr. de Graaff.